Please join me in welcoming Dr. Drozd to the stage.
Perfect. Well, welcome everyone. So my name is Dr. Amy Drozd, ER physician turned ketamine provider. And today we're going to talk about how ketamine can change outcomes by just addressing the nervous system. A talk that I've titled From Hyperarousal to Receptivity. I have no disclosures, financial or otherwise. We'll first talk a little bit about our practice in the setting that these clinical observations were made, and then the hypothesis that we came up with and the rationale behind our study. We'll describe the methods and the design, and then we'll talk about the real-world outcomes. And we'll leave some time to discuss those outcomes, limitations, and some questions. In the world of ketamine, we often describe our clients as responders or non-responders. But truly, in the trenches, it's much more complex than this. Some clients respond and we see really great gains, but then they start to plateau and those gains start to dissipate. We see some patients that just fluctuate from treatment to treatment, and we see some that improve, but not truly. They don't identify with health, they're just getting better. And conversely, we see the opposite. We see some non-responders that over time start to respond. And so for us, the people that are doing this, we see our clients turn to us and say, what do we do? What's happening? What should I do different? This is a large category that our team likes to address and identify them as partial responders. And at least 20% or more are partial responders. And this topic is addressing this population. But before we jump into that big topic, I want to describe a little bit about the context of our office, because set and setting is everything. And where we do this and how we do this might differ from how you do it. And I want you guys to be able to compare notes. So for 3 years, we were a pure IV and IM practice, focusing on really intentional integration. So every phone call had a discovery call, and during that discovery call, clients were screened, making sure that they understand what they're signing up for. This is not a quick cure. This is a program and a process. Those that made through the screening had a medical assessment. I did every medical assessment. Briefly, we'd make sure that the client's safe, but ultimately we spent most of that time identifying what that client needs and determining their intentions right there, and then giving them homework. I wrote a workbook, and they're given a workbook, and they have to define their intention, and we have a series of questions that get them to the place where they identify with what could healing look like, and then they have a mindful process that they're invited to start and do daily. Every client gets a coach or a therapist, and then that coach witnesses their initial intention and then mirrors each one of their treatments so that they continue to heal. So fast forward, 18 months ago, we started to use Spravato as well, and the methodology didn't change. Every client still gets this, high-touch room, eye mask, headphones. Just because we're using Spravato doesn't mean we're not using the full CAP model. The client is now, with Spravato, the dose is standardized. The access has significantly increased, but they're still invited to follow general ketamine-assisted therapy protocol and methodology. And as I'm sure all of you are seeing, moods are improving. Motivation is improving. Patients have more cognitive flexibility. Hopelessness is decreasing. But what about these partial responders, right? Where we feel like we're doing everything right, but not everyone's getting full treatment results. When we slow down and interview these clients again, when I'm reading the therapy notes, because we are sharing our notes, what we're seeing in the practice and what we're seeing in coaching, I'm noticing a signature, a pattern that's common among the clients that aren't responding as well. These clients are still having strong experiences of rumination. They're still having anxiety, this persistent insomnia, hypervigilance. this exaggerated startle. They're just still in a different state. We're noticing transient and sometimes persistent mood increases, but their nervous system is telling a different story. They seem to be in a state of threat. So we're wondering, how can we address the survival component? Or really, when we talk to the clients, they report this in a different way. The clients, when we really slow down and ask them, they'll report that they've had some degree of prior trauma. And it's often small t cumulative trauma. So in the interview, the client may not identify with PTSD, because that's a veteran, that's a big thing, not me. I just had abandonment, neglect, that one thing is a low memory of something that was traumatic. But by the time they're old enough, teenagers or sometimes a little older, to seek therapy, counseling, or had a psychiatry evaluation, then they're typically pathologized and they're diagnosed with bipolar disorder, depression, any of these OCD diagnoses that are causing them to dissociate from their traumatic experiences. So why does this matter? This matters because our model is strongly rooted in the ketamine-assisted psychotherapy model. We don't think that the molecule is here to fix this. It's definitely an important part of this, but that's only one part. Ketamine therapy really requires emotional openness and meaning making that is done in the coaching space. But if patients are in a state of hyperarousal and they have trauma that hasn't been resolved, their treatments look like defensive dissociation. They're still avoiding emotional depth. So even though they're having the treatment, they're only going halfway down and they're not getting a true cathartic release. And then the integration isn't as effective. So even though their mood's improving, they're not fully responding to the treatment that we're offering. So our team heard this, and we started to ask new questions. If ketamine was helping cognition and mood, but the body was still stuck in threat, were we missing a really important step in the treatment sequence? What if there's a way that we could treat the nervous system first? And something serendipitous happened. I'm sure most of you are here because you had your job and then some opportunity showed up and like, God, well, how amazing would it be to do this ketamine psychedelic work? And most of us had that turning moment. And this was one of them. I had just had the fortune of being on the Third Wave podcast, and a friend, an ER doctor friend of mine that I had done 6 months in Nepal with, calls me out of the blue and says, hey, I just heard your podcast. I did the same thing. I've left ER and I do this non-traditional work and I do ketamine work and these other modalities. And she asked me a question that I embarrassingly didn't have an answer to. She asked, what do you do with the population that are too stuck and too boundaried and too anxious to respond to your ketamine work? And at that moment, she said, you should explore stellate ganglion blocks. I could teach you. It's a really valuable asset. So I jumped into the literature, and there was a lot of it. Really large clinical trials, a huge amount of VA evidence, all looking at PTSD. There was really strong reviews and case series. So this one particularly is from the people that really put stellates on the map for being used for mental health rather than pain syndromes. So the evidence was clear that this has been an established intervention for PTSD, but also hyperarousal, anxiety, and sleep disturbances. So I decided to take her up on her mentorship, and actually it was a colleague of her that trained her that was available for that. And we decided to add this treatment to our team's approach, specifically to treat what ketamine wasn't. And within months, we were offering this, and we were pleasantly surprised to see that we were seeing exactly what the data was showing. Clients, their PCL5s were dropping, and PTSD symptoms were improving almost immediately. People had decreased arousal, decreased reactivity, and everyone reports that their best night of sleep in their life is that night. So there was lots of subtle changes that we saw, but we weren't measuring it strong enough to identify whether or not it was meaningful yet. But there was something else, though, an unexpected finding that was very interesting, and that's what I want to go into next. Before I explain it, with the consent of one of our early clients, I'm going to play you this 2-minute video.
Hey everybody, my name is Corey Richards. I am a former professional athlete doing high altitude climbing. I was also a photographer for National Geographic, and I did a lot of conflict photography. But also I grew up in a pretty complicated childhood. I was institutionalized, I was on the street. And so I've had a long journey with mental health, and all that to say that in my childhood and leading into my adult life and the things I was doing for my career, there was a lot of hyperarousal. I've been on my own healing journey now for a lot of years, and I've tried a lot of different modalities and a lot of different psychedelics. I've done high-dose psilocybin, I've done a lot of ketamine therapy, I've done MDA and MDMA therapies, and I've done 5-MeO-DMT. I tried the stellate ganglion block because I felt like even though all those were helpful, there was still like my nervous system oftentimes felt stuck. Right. And so I was always in that hyperarousal and stuck in that fight, flight, or freeze. And what changed for me was by doing the stellate ganglion block first and then doing a ketamine treatment directly after, I felt like by calming the nervous system first, I was able to access deeper connections. I was able to go to the sort of the basement of myself, because even with all the work I had done, I was still kind of stuck there at times, or I get brief relief and then I would go back into it. So I think why this matters is because it does do that. It calms the nervous system first. And then so it's not just about relief. And I'm really excited that this is being explored, because for me, it had tremendous benefit, and it was super, super helpful long term. So anyway, that's my story. I hope you guys are having a great day. Thanks.
So what was so surprising is the clients were coming back and giving us these really profound testimonials, emails and phone calls saying, this was very different. This felt a little bit like my first treatment, or maybe bigger than that one. And what was interesting is the clients were saying, I'm happier. This wasn't addressing the mood disorder of depression. What they were saying is, I'm less guarded. I could stay with my emotions. I'm more present. And then back in their life, not during the treatment, I'm less dissociated. This thing that triggers me happened, but I was just able to move through it, which to us suggested that we're changing people's baseline arousal, which brought us to this hypothesis. We started to think that we're onto something. Let's explore this deeper. So this new idea was, is the nervous system state determining how well ketamine works? We can all kind of conceptualize that, but we realized that we could actually measure this. So we wanted to ask, could the stellate enhance receptivity to our existing model of ketamine psychotherapy? So I designed this study with this hypothesis, with the primary outcome being something that I was convinced would be determined. We thought, let's make sure we measure whether or not people with trauma have a decreased PCL5. But we also wanted to add this exploratory hypothesis with 3 variables. First, does it address anxiety specifically? Second, does the altered state that this client and others were reporting, could that be measured, and could that be identified as something that's augmented through this process using the MEQ30? And then lastly, does this improve depression? Most of our Spravato clients were clearly here for TRD. Does it help with that? So the clients that we enrolled for this had PTSD and or hyperarousal and or panic, insomnia, or general anxiety. It's pretty wide. I mean, honestly, anyone that's survived a pandemic or has looked at a headline in the newspaper the last 3 months would probably fit this criteria. So we identified 50 clients and ultimately enrolled 36 of them. So all of these clients, all of them were in our existing recurrent ketamine model. They were either doing IV and IM, or they were in the Spravato treatment. Of this demographic, 36 were in the induction phase, and 64% were in their maintenance phase. We define this, induction is defined as less than 6 treatments if they're doing IV or IM, and less than 12 treatments if they're in the Spravato model. Anyone above that, whether it's 1 treatment more or 20 treatments more, was considered maintenance. And these clients, we didn't tell them that this would change their treatment. What we said is that this would help with their hyperarousal. We're treating nervous system dysregulation. So this kind of study is a within subject comparison. So the clients are their own controls and variables. And what changes is the time. So the way we measured it is we used these 4 questionnaires that I described. And when the client was screened and agreed to do it, we measured those 4 screens right away. At that time, we scheduled them for a stellate ganglion block. Then we measured the same 4 questionnaires 1 to 3 days after. After their stellates, we scheduled another ketamine treatment and measured the results of that 1 to 3 days after. So the methods, every client was screened for the procedure, make sure it's safe. Patients were excluded if they had infection on that site, coagulopathy, or a known allergy to any local anesthetic. Everyone was NPO for 4 hours. We collected vitals numerous times, and everyone was consented thoroughly. Every treatment was ultrasound guided, full real-time ultrasound guided, watching the needle the entire time. We used 2 different machines. Most of them were with the Butterfly IQ3, but also we used the GE Logic ER7. And we made sure we saw everyone's anatomy before we proceeded. Here's a quick video. I'll let you watch it through, and I'll just define a few things on it. So this is the tubercle that's an important landmark. This particular one is actually C4. For everyone we went through, identified their arterial vessels. That video showed how I compressed and decompressed the IJ, the venous vessels. And these 2 bodies are really important. This is the longus capitis and longus coli. And the stellate is this, and it sits between them. And so we scan from around C2 down to the first rib and identify all vascular structures, nerve bundles, and muscles so that we have the anatomy, and then we start, and the procedure goes pretty quickly after that. We use ropivacaine. There's other options like Marcaine or bupivacaine, but it's a little bit more cardiotoxic. So every client had a dual sympathetic reset. So they get 2 sites. We injected either at at C6 first with 7 mLs, and then at C4 with 3 mLs, a total of 10. And I'll show this. It's hard to resolve, but this is the same area, and you can kind of see the distension. The needle is right here. If you keep your eyes right here, you'll notice the tissue is being hydrodissected by the ropivacaine. So we visualize it going in, then my tech is there, and you can see that stretching right there. You can actually watch the medicine go in and watch it move the stellate up to the side. It's pretty visually confirmatory that you're in the right site. And then we only inject if we know we're not in a vessel with negative aspirations, and it's very standardized. We can confirm the block pretty quickly by observing an ipsilateral Horner syndrome with ptosis, anhidrosis, meiosis on that side, and then subjectively the clients will report that they have a change in temperature in their face. And we have a lot of time. We monitor clients for a minimum of 30 minutes. Some stay for hours afterward, reassess their vitals, and watch their side effects. The 4 most common is hoarseness, dysphagia, dyspnea, and you could have some neurological symptoms. Of note, they're not rare, but they're not challenging. Mostly the hoarseness is the most common one. And none of our clients had any complications from their symptoms. So let me speak a little bit to the study design. So it's the strengths, I think, are that we're using real clinical population, and it's within subject comparisons. So we really are understanding in a high-touch model what our clients are doing and what our population was doing and is going to do going forward. And I think that this would be really helpful, or rather, when designing this, we knew this would be helpful to discuss with the colleagues that I speak to normally, and also this population, so that you can think about how this can be used in your practice, not so much what the clinical trial is saying. But there's also some significant limitations. This was not a randomized controlled group, so there's going to be some bias. This is a practice-based observational study, so we're looking at the homogeneous Santa Barbara population. And I think maybe the biggest limitation is it was a pretty short-term follow-up window. So there's a lot more we could learn by looking, really breaking up the populations, but then looking further. So I think so we're going to start look at the demographic and then start looking at the results. So our clients at baseline identified with severe depression, severe PTSD. They had moderate depression and moderate to severe anxiety. And then I'll just go into exactly what the results look like. So as expected, we noticed a statistically significant drop in the PCL5s. So this did help the clients that identify with depression. What you'll see, though, is aside from there being an initial drop, there's a continuation of this trend, which we weren't sure we'd see, but it was really encouraging to identify. But I think there's some bias to it, too. When we do ketamine treatments, when someone has a profound response, they'll tell you that day before they leave just how meaningful it was. With stellates, I'd say about 15% of clients leave really moved, but a lot of them won't really notice the pure benefits until the next day or at maybe 2 days later. So with this, it's hard to say whether the value of the stellate was continuing to unfold and they're appreciating that alone, or whether the ketamine experience influenced the benefits in the drop in PCL5. I was hoping I'd see this, and we saw a statistical significant drop in anxiety as well. Little less so than with PCL5s, but close. So this does support our desire to expand the opportunity to use this from only clients that have trauma to clients that identify without full trauma, but maybe more anxiety. And then we looked at our existing, depression scale, the thing kind of most clients are really here for. And I wouldn't say that statistically, my statistician said there was some reduction, but it was subtle. I'd like to say that, a lot of the clients were already in maintenance and that we'd already partially cured some of their symptoms, but ultimately this is a place where we could really do repeat trials specifically looking at different time sequences. But most importantly, no one was getting worse. It was getting subtly better. And this is the data that I was most excited about. And by looking at this graph, the dot plot graph, it's kind of hard to identify what to make of this. It looks like maybe I got a little better after both treatments. But I asked my team to look at the individuals that made up this plot. And if we really look closely, what I was able to appreciate is actually quite dramatic. 53% of clients didn't identify a significant difference. The score was statistically the same. 6% reported a score lower, but 31% identified that there was a significant change in the quality of their altered state after their treatment. One client actually reported 150. They gave a perfect score, 5 out of 5 out of 30 questions on their MEQ 30. And this is not subtle. These people have these people are looking for health. They're not specifically looking to have a big altered state of consciousness, and they had a big experience, and 30% I think is pretty remarkable. And the last thing I want to comment on is the response rate was really high. When I really look at this, it makes this strengthens our numbers greater than we've ever seen. If we just look at the PHQ-9, our team is proud to say that we're doing better than the national statistics, and we're in the mid to high 70s with our response rate of our IM or our Spravato treatments. But if this alone got us to 83%, it would be worth doing. The truth is, it's a small population size. I don't know if this is enough to completely change our protocols, but it's meaningful. So let's discuss. But let me slow down and describe the stellates. So for all of you that didn't go to Samko's really great lecture last year or don't really know much about this procedure, I'll give you the big picture. So the thought is, with trauma, the body keeps the score. And it's true that our cells kind of are primed and ready to respond more quickly to a former insult. The problem with that is, if that insult isn't real, we end up living in a state of hyperarousal anxiety for our whole lives without actually needing to. So the way that these catecholamines of anxiety are communicated to the limbic system and the amygdala is through a pathway to the neck, the superior cervical chain, and specifically the stellate ganglion. So the purpose of this treatment is to use a non-psychoactive numbing medicine like Novocaine, but super long-acting, Repivicaine, to block at these sites so that for 8 hours, you can't experience stress. The goal is not to give you 8 hours of relief. The goal is to pause these messages and show your brain that they're not real and allow you to reset. And so we call this a dual sympathetic reset by decreasing the amygdala-driven threat signals. And for us, this allows a greater emotional tolerance for our clients, and it allows the ketamine to be more plastic and usable in ketamine-assisted therapy. So this allows for a clinical reframe of these non-responders or these partial responders. I'd like to give every client the benefit of the doubt and to think that biologically they could all respond to ketamine. So the question is, are they physiologically able to receive the treatment, not biologically? And so this allows us to consider whether every partial or non-responder can become a full responder if we modulate their autonomic nervous system by giving them a felt sense of safety. Because remember, during these treatments, they weren't saying I'm happy. They're saying I'm feeling less guarded. And this is what they're saying during the treatments. Less guarded. I can actually stay with the emotions. Maybe they were like actively pushing it away. I wasn't fighting the experience anymore. And I love this one. I remember I could picture the client. It felt more meaningful, not just strange. So this isn't a transient anxiolytic. The purpose of this is to alter the relationship to our existing treatment. So this actually changed my practice immediately. The next medical assessment I did, I made sure I started really screening people for autonomic dysregulation. I asked them, do you identify with trauma? And I give them the space to talk about their little T's and when they first, what happened in their childhood, what happened in their life that brought it to that appointment, but really how did their mental health journey begin? And it makes me, and at that time, I started, for the people that it fits, I start to talk about a stellate right away. We may not prescribe it, we may prescribe it, but the conversation starts really early and we decide, depending on how they respond, if they need one. And so I connect with my coaching therapy team and I invite them to use a new clinical lens. When a client tells them they're not responding, I want them to say, why isn't this client responding? I ask them to look at, is that patient physiologically able to receive the therapy that we're giving them right now? Because I want them to reframe the problem might be nervous system readiness, not physiological willingness or medication failure. And that's what we formerly did. So in conclusion, what clients were describing is less fear, more emotional openness, and a greater ability to make meaning of their treatments. And most importantly, the medicine didn't change and the coaching and therapy didn't change. What changed is the nervous system state when they started the treatment or just had their next treatment. So for us, we're changing our protocols. I ask everyone on the team to consider this, and if a client is bringing up trauma symptoms and they're a partial responder, we should discuss this and consider whether they should be offered a stellate ganglion block. And the takeaways that I'd love for you guys to have from here is stellates work really well for PTSD. So if that's all you're looking to do is help someone with that symptom, find someone in your area that offers them. But it also reduces anxiety and enhances the depth of the altered state offered by ketamine therapy. So this suggests that stellates may function as a preparatory intervention or enhance existing interventions. So, but this is just the tip of the iceberg. This is something our team speculated might be helpful, and it was helpful for us. But really, we need to, or someone needs to do a randomized study. We need much longer follow-ups. It'd be interesting to see what physiological markers influence this, and even phenotype-specific targeting. This is maybe a third of our team. A few of them are here. Aubrey in the left, in the black, she's on your right. She helped me collect a lot of that data. But thank you for your attention, and I'm happy to answer any questions.
What are the potential complications of performing a stellate ganglion block? And follow-up, is it safe to do bilateral blocks on the same day?
Yeah, great question. These are very technical. I did ultrasound in my residency. I've done 1,000 intrajugular canalizations. I've never done one non-ultrasound guided. So you have to be good at ultrasound. But when you do it, you're going really close to the carotid, really close to the internal jugular. And in the event that, no vascular bundles are compromised, then there's very few complications, or any risks beyond an immediate complication. Obviously, you break the skin, you can have an infection on that site, but we clean this site off. But this is interior to the spinal cord. A lot of clients are worried, and if one of the first questions is, can I get paralyzed? Is it going to cause any kind of neurological problems? The truth is, we're nowhere near there. So it's 100% dependent on the technician, the person offering it. But the biggest risk is hitting a vessel. And can you do bilaterals? Yeah. We decided to do one side. My Eugene Lebov and Dr. Howe from Stella that I worked with, they believe in if there's a response on one side, then you don't do the other side. It's not safe to do both sides at the same time because it does impact the recurrent laryngeal nerve, which will affect your ability to protect your airway. So in the event that you have a big laryngeal effect on one side and the other side, it's dangerous. So when clients want bilaterals, we could do one the first day, and then 24 hours, you could do the other side.
Perfect, thank you. What's the average cost to the patient for a block, and then how long do their results last?
Great question. It's highly variable as far as price goes. I know Stella charges $2,500 for theirs. We started low and we went up. We charge about $1,000 for ours to simply pay for the cost of the training, the equipment, and the time. But we feel like we're easily charging half of what some places do in LA and near us. The effects, it's variable. I'm treating someone for their 5th stellate this Thursday because they had a big T trauma, and she reports clearly for 2 months, she's back to normal. The person before that traumatic event 5 years ago. But I'd say 3 to 6 months is the common reported benefit. But some of the things that you gain from it never go away. You start to understand your trauma better. But for that experience of relief continuously, I'd say 6 months or less is what I tell clients.
Okay. Do you give a block before KAP?
Yeah. Not before I started. And actually, this is interesting. I thought about this as I'm presenting it. Even though I'm talking about preparing clients with this before we start, I very rarely do one before they start the program, because ketamine is so experiential and it's so cognitively subjective. If they don't know, if they're naive to psychedelics or ketamine and they have no idea what they're getting, they can't kind of compare how much more intense it was. And I'd rather let them know what both feels like. So a common program for someone that identifies with depression is to do 2 like intramusculars, do the right side, do 2 more intramusculars, do the left side, and then do the last one. That would be a 6 series with bilateral stellate ganglion blocks.
I think we have time for one more. The average number of blocks these patients received?
1. Most people really appreciate 1, learn a lot from it. And it's, I'm beginning, I've been doing this for less than 2 years, but more than a year. I'm beginning to see that patients come back. They might start coming back about once a year for the ones that really appreciate it. I think that will be common.
Fantastic. Thank you.
You're welcome.